Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be exploring counseling a patient with moderate to severe atopic dermatitis. Our moderator this evening is Dr. James Del Rosso, who's Research Director, Principal Investigator at JDR Dermatology Research in Las Vegas, Nevada, Adjunct Clinical Professor of Dermatology at Touro University, Nevada, and Henderson, Nevada, and President of the American Acne and Rosacea Society. Our speaker this evening is Dr. Samal Desai, who is founder and medical director of Innovative Dermatology, clinical associate professor at the Department of Dermatology, University of Texas Southwestern Medical Center. We would like to thank our supporters, Pfizer, for making this educational event possible. Before we begin, if you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question chat pane. It's on the right-hand side of your screen. At the end of this webinar, a survey will pop up in the browser and will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of the webinar, a certificate of attendance will also be sent to you. So without further ado, I will pass the floor virtually to Dr. Del Rosso.
Thank you, Roxanne, and welcome everyone. It's a pleasure tonight to have the opportunity to host in Dr. Leon Kircik's absence. He was not able to be here tonight. He's usually in this role. He's asked me to fill in, and it's an honor to have my good friend and colleague, and recently finishing up as the president of the American Academy of Dermatology. So if you're wondering where Samal, he was a lot of different places, but we're thankful to have him with us tonight. We'll get to him in a moment. So the International Dermatology Education Foundation, this is something that was actually founded by Dr. Leon Kircik and has really been a great addition to dermatology. It's a nonprofit organization that has a mission of raising awareness and improved dermatologic care, not only in the United States, but all around the world, even reaching underserved areas. And there's a variety of different programs that have here's some past ones, and then there are future ones coming up. And stay up to date with IDEF educational seminars. Here's how you can do that. You can visit www.idefeducationseries.com to register for any upcoming events. But tonight's going to be a very exciting one. So I'm going to introduce and get this ball rolling. Counseling a patient with moderate to severe atopic dermatitis, the inimitable Dr. Samal Desai. Great to have you here, Samal.
Jim, thanks so much for the kind introduction. Thank you to Roxanne for helping to always facilitate a great intellectual dialogue, and most importantly, to Leon Kircik for putting together the IDEF and allowing them the opportunity for us to share these great ideas this evening. I'm looking forward to spending the next several minutes with you all talking about moderate to severe atopic dermatitis, and then hopefully have the opportunity to answer some questions along the way. Next slide, please. So tonight we're going to have the opportunity to talk about CIBINQO, and I'm excited to present the next several slides with you. I want to thank Pfizer for helping to support this program, and most importantly, for continuing to bring innovations in treating our patients with moderate to severe atopic dermatitis, specifically with CIBINQO, or known as abrocitinib, a once daily oral medication for patients now ages 12 years and older with moderate severe atopic dermatitis. And we're going to walk through this throughout the next several minutes, talking about the practical applications and considerations of CIBINQO, both from a counseling perspective and as well as sharing with you some data. But tonight's going to be a little bit different because I really want to walk you through how to approach incorporating CIBINQO into your therapeutic armamentarium. Next slide. There are some important disclosures that I am required to share with you. One is that I've been a consultant for Pfizer and have worked on CIBINQO for the program tonight. As a part of that work, we are being supported and sponsored by Pfizer, and everything we discuss tonight will be per FDA regulations, per the FDA package insert, and as such, you are all aware that these programs are not entitled for CME but we will remain completely on label and fully compliant. Next slide. Now, what I'd like to do is kind of break this up into different sort of what I like to call columns. And we're going to build these columns into a beautiful structure by the end of the talk. And we're going to first talk a little bit about how CIBINQO is a small molecule JAK inhibitor. It's not a biologic. It works intracellularly. I also want to update you on the new safety data that's been found across many clinical trials. Over 3,800 patients actually have been evaluated in safety. And I'm also excited to tell you that the long-term safety study is currently in progress, continues to be evaluated. So more rich data is soon forthcoming in the future. I'm going to talk to you about the JADE clinical trial program. The reason that's important is because I want to show you the data in real life scenarios, emulating what many of us do in our practices with a topical steroid, comparing to other therapies for atopic dermatitis. What do you need to know from a practical perspective? And then finally, starting and monitoring your patients with CIBINQO. Next slide. Now, as you know, CIBINQO is an oral medication, as I've already mentioned. It's a once daily therapy approved for adult and pediatric patients. Very important to know, this is FDA approved in patients ages 12 or above who have refractory moderate to severe atopic dermatitis, and those patients whose disease is not adequately controlled with other systemic products, including biologics, or when use of topical therapies or other therapies is inadvisable. So this is for our patients with moderate severe AD, again, whose disease is not adequately controlled with other systemics, including systemic biologics, or when those therapies are inadvisable. The one thing we want to just mention is that this therapy is not for use in combination with other JAK inhibitors, biologic immunomodulators, or immunosuppressants. And I know that many of us worry about package inserts and important safety information, also known as ISI. And I'm going to share that with you in a few slides about how to interpret the package insert on label, but also in the context of the clinical trial. And we're going to talk a little bit about that. Just a quick call out. The one contraindication you need to be aware of is that in patients who take antiplatelet therapies, prescription antiplatelet therapies, except for low-dose aspirin, so that's allowed, if CIBINQO is contraindicated in patients who take antiplatelet therapies in the first 3 months. Just keep that in mind. It's probably not going to be the vast majority of your patients. I know in my practice, certainly we haven't really run across that. This is the call out on the package insert that I want you to be aware of. Next slide. So let's begin by talking a little bit about understanding the role of CIBINQO in atopic dermatitis. And as we go to the next slide and then onward, I'm going to be able to share with you a little bit more detail into mechanism. And many of you may have heard me start talking about JAK inhibitors back in 2014, when we were not even on the cusp of any FDA approvals. Let's go into the next slide, and that'll kind of remind you a little bit about how far we've come in this. When I first started talking on podium about JAK inhibitors before any FDA approval, I was very excited about these therapies because in these treatments, the disease pathophysiology fits the mechanism of the drug. You can almost use the mechanism of the drug and even walk in reverse direction to better understand the mechanism of the disease. And I think that's been really fascinating. And this slide is a beautiful example of that. And what do I really mean? Well, what I mean is that when you think about how atopic dermatitis clinically manifests, it manifests through a variety of different cytokines that drive the inflammation. But how do you know that a JAK1 inhibitor versus, let's say, a JAK2 inhibitor, or a JAK1/3 inhibitor, or a TYK2 inhibitor, or whatever moniker of JAK-STAT family you want to talk about, how do you know that that JAK treatment is really designed to help the inflammatory pathway of your disease? And the reason you know that, and I'm going to build on this in just a few minutes, is because certain cytokines really signal through specific JAK family pairs. And that's how you really know you're targeting the right blockade because these cytokines, if you don't block them, are upregulated through a certain JAK pathway. So just to bring this up to speed, you all know that IL-4, IL-13, TSLP, IL-31, interferon gamma, and IL-22. Some of the 7 key cytokines, if you will. Now, are there others? Absolutely. But these are the key crux cytokines that we know regulate downstream gene expression. For example, IL-31 and TSLP extremely connected to pruritus. We know that downregulating and blocking the signaling of TSLP and IL-31 into the cell, into the nucleus, helps relieve itch. I'm going to show you in a few minutes how CIBINQO helps with that and show you the data. IL-4 and IL-13 are thought to drive atopic inflammation. Interferon gamma is implicated again in that barrier and inflammatory response, as so IL-22. Now, so this is meant to kind of show you that these cytokines, when they signal through the JAK-STAT pathway, and look what you see inside that cell. What you see inside that cell are those small sort of oval-shaped proteins, the 2 JAK pairs. So notice that TSLP and IL-31 go through the JAK1, JAK3 oval-shaped proteins. Whereas IL-4 and IL-13 do a lot of signaling through JAK1 and JAK3, but also JAK1 and TYK2. And so what is the commonality amongst these cytokines? The commonality is the blue oval-shaped piece there, JAK1. There's a lot of commonality. Please, Jim.
One of the things that I think is important too is that not every patient's the same in terms of which of these different cytokines may be more dominant or less dominant. So if a patient just happens to have less of the IL-4 and IL-13, but more of the interferon gamma playing a role based on their genetic endotype, you're still covering that pathway by targeting more of these different signals as opposed to just one of them or 2 of them.
Such an important point. I completely agree. These cytokines are meant to be illustrative, but every patient's profile is going to be different. The beauty of this is, though, you see the commonality with JAK1. And so the theoretical help is no matter what profile your patient has genetically, you're hopefully going to quench it because you know that they all at least have common signaling down one pathway. Great point. Thanks, Jim. Next slide. And actually, we're going to come back to Jim's point in a minute because that's going to be helpful when we look. Actually, let's go to, this slide is really important because this helps to, again, highlight a little bit, Jim, what you just elucidated, which is that as a small molecule, as an intracellular small molecule that reversibly inhibits JAK1, that blue-shaped oval that you see intracellularly there, by blocking that ATP site, you know that abrocitinib, which was shown in these enzyme assays that were done, was selected for JAK1 over JAK2, JAK3, and TYK2. And this illustrative mechanism of action helps to see why if you block that, then you don't get that STAT signaling into the nucleus. And the STAT is the fuel to the train engine down the tracks. So I always say, think of the DNA transcription, think of the DNA as your train tracks. The train is ready to leave the station. It's got to have the fuel and the coal to do it. That's your STAT. But until you get that STAT there and you block it, the train can't leave the station. And this is really how it shuts it down. Okay, next slide. So let's talk a little bit about the safety profile. And normally in a lot of these talks, we always do disease state and MOA, and then clinical studies, and then efficacy, and then safety. I love what we're doing tonight is we're going to start with safety. We're going to flip the script a little bit. So let's look at safety first. Let's go to the next slide. And we're going to go through a variety of different safety points. But what I did want to go ahead and build on, and let's go ahead and build this out, because this is a beautiful timeline of the JAK inhibitor innovation. Back in 1993, these disease state class of therapies were actually discovered. 2012 was when Pfizer developed JAK inhibitors and the first in class to receive FCA approval for clinical use in immune-mediated disease. Then in 2016 is when the phase 2b studies started. Now remember, I just mentioned in 2014, I was at many of our meetings, Fall Clinical, the AAD, talking about the potential benefits of JAK-STAT in immunodermatology. And it's really fascinating because the timeline of Pfizer's commitment to this work started so many, many years before that. In 2018, there was a breakthrough therapy designation for abrocitinib. I actually don't think many people know that in 2018, abro actually received breakthrough designation. And then in 2021, the FDA announced that JAK inhibitors that treat certain chronic inflammatory diseases had additional potential safety signals, but that was announced in relation to JAK inhibitors for patients with rheumatoid arthritis. We're going to come back to that. Let's build the timeline a little bit more.
So Samal, how old were you in 1993? I was 39.
That's a good one. You know how old I was, but
yep.
It's good to know that it was still happening.
Yep.
And then in 2022, we get CIBINQO's approval for moderate to severe AD, and then let's fast forward all the way to the last two bills and keep going to 23 and 24, and then we get to present day, and we see now the FDA approval down to the age of 12, and we also see that we have long-term data that continues to move forward. So let's go ahead and click through, and then let's talk a little bit about here the box warning. So I mentioned a little bit of that earlier. A couple of things to mention and call out. Patients with malignancies. Malignancies have occurred with CIBINQO. There were higher rates of lymphoma and lung cancers compared to another JAK inhibitor versus TNF in RA patients. We do have a call out that patients who are current or past smokers are at a risk. That's something we ask all our patients about. So that should be nothing different from what we as dermatologists do for any systemics. Serious infections are listed, including herpes simplex, herpes zoster, and pneumonia. What do? If a patient develops a serious or opportunistic infection, you stop the therapy. Testing for latent TB before and during therapy and treating latent TB prior to its use. You all are familiar with that. Monitoring for signals of TB. And if a patient has an active infection, you would obviously want to treat the infection before putting them on a therapy like this. If you read this, you read it and you say, well, this is a lot of what we already do. And it's just a matter of thinking about it in the context of what you do in your clinical practice.
You know, the other important point is that, and this is true of a lot of the different therapies and certainly true here, these box warnings are not specifically contraindications. They're not telling you that the only contraindication is related to those antiplatelet therapies. This is just being cautious in terms of how you're prescribing, which we've done with many of the therapies for years. So it just puts some responsibility in our hands.
Yeah, and I'm really glad you said that because our job as dermatologists is to help our patients who are suffering. Moderate and severe AD patients are suffering. And especially these patients who have failed biologics or when those other therapies are inadvisable, these patients need our help. And so what I hope people leave from tonight's talk, Jim, is not being scared of what's listed on a box warning. In fact, to embrace and understand it in the context of what you're probably already doing if you're prescribing methotrexate, a biologic, cyclosporin. I always love when I hear from our other colleagues, read the package insert of prednisone, read the package insert of ibuprofen. It's really interesting how we tend to go in these spheres and we don't look holistically. And that actually brings me to the major adverse cardiovascular event piece. That's called MACE events. Of course, if a patient is an active or current smoker or past smokers, they're at increased risk. You don't want to use CIBINQO in a patient having an MI or a stroke, and you would discontinue if they have this event. Higher rates were identified with another JAK inhibitor. So please read the language that MACE has occurred with CIBINQO. Higher rate of MACE with another JAK inhibitor versus TNF blockers in RA patients was seen. So the FDA is calling out TNF blocker patients with RA who were then put on another JAK in this all-class warning. And I think that's something to keep in mind. It says the same thing for thrombosis. And we'll come back to this in just a few minutes. Next slide. So let's keep going. And this is again where I was talking about the Academy's guidelines. I'm really proud that the AAD guidelines now include CIBINQO in the oral category. And of course, as I mentioned, studies are ongoing in 2024 and 25. So some big things, okay, risk factors. You know, a lot of people like to say, well, okay, they've got a cardiovascular risk factor or they're a current or former smoker, they're not going on an oral JAK. So what I want to mention, and this is on label, that in even patients who had risk factors were included in the study. In fact, if you look at the composite data, over 45% of patients who had at least one cardiovascular risk factor were included in CIBINQO clinical trials. And so just to Jim's point, just because they had hypertension and diabetes or hyperlipidemia, they weren't excluded from the trial because it was not a contraindication. They were in the trial with a patient to physician discussion and monitored throughout the trial like any clinical trial subject. So this breaks down the data between CIBINQO 100 and 200, 100 in teal on the left, 200 on the right in the blue. Those colors are going to follow us throughout the slide. So when you see that tealish color, you'll know it's the 100, and then the royal blue more of a 200. But you see there were 197 subjects who were current smokers in the CIBINQO 100. There were almost double that in the 200. Obesity was also present. You know that many of our atopic dermatitis patients feel very uncomfortable being active, exercising, going to work. Many have a sedentary lifestyle because their skin is inflamed, pruritic, lichenified, all of those things. Things that I don't have to tell you. We're all dermatologists. We've all seen this in real life. But what I wanted to say is, while we want to consider the benefit and risks of individual patients prior to initiating CIBINQO, keep in mind that these patients were in the study as well. So the studies represent real life scenarios. None of our patients live in a bubble and are completely immune from everything. Next slide. Now, also here, this is an important slide that talks more about those adverse events. So what we want to show is that in this chart, this lists these adverse events. For example, was herpes zoster seen? The answer was yes. Now, was it seen a lot? The answer was no. Notice it says 3 for 100 and 8 for 200. Notice that under malignancy, there was 0 reported. DVT, there was 0 reported. And what 0 means is that no cases were observed during the reporting period. This doesn't necessarily mean you want to think about it as there's absolutely no risk, because we know what the package insert says, but there was 0 reported during this placebo-controlled pivotal trial up to 16 weeks. Really important to think about that. MACE events, 1 reported in 100 and 2 reported in 0. 0 reported in 200. I'm not asking you to imply anything about what I'm saying. I'm just presenting the facts. The numbers speak for themselves. And these are the numbers in the incident rate per 100 patient years. Next slide. Now, one of the things I also wanted to kind of bring back is that we're now at close to 4,000 patients with close to 5 years of exposure in some patients of drug, and we're continuing to get long-term data. It's really important to remember that over 2,000 patients who were treated with CIBINQO had at least 48 weeks of exposure to the drug, and over 800 had at least 144 weeks exposure to the drug. So we're talking a long time, over 2 years. And this gives you, again, these AEs of special interest, and we can certainly talk about these during discussion if anyone has any questions. But these pooled safety analyses are really important to see. So let's take another example. In the 100 arm, the rate of MACE events in incidence rate per 100 patient years was 6 in the 100 and 9 in the 200. This is again looking at overall integrated safety analysis, including the JADE Extend of approximately 3,850 patients.
So the way I read that, Samal, is it's 0.3 patient in both of those. That means 0.3 of a patient out of 100 patients treated for a year develop that. And what I think is interesting is you're doubling the dose, but some people might intuitively think, well, then I'm doubling the safety risk.
Yes.
And that's not the case, right?
It really isn't. And
Yeah.
looking at the incident rate per 100 patient years, I think is actually really important, because that's how you look at the composite, to your point.
Right.
You're looking at the whole cohort there. And to your point, the MACE events numerically is the same. It was 0.3 in both. Next slide. Now, the other thing that I wanted to mention is that this data shows us the selected adverse events in a matched atopic dermatitis cohort. So, for example, the Kaiser cohort of 2007 to 2018, this was for members of this cohort aged over 12, moderate to severe atopic dermatitis, who were all put together in this entire composite. And so if you look specifically at the CIBINQO rates, and then you look at the Kaiser cohort incidence rates, what do you see? What you see is this really interesting generalizability. Now, we know that this data is, I'm generalizing, and observational cohort data have limited generalizability outside of the included populations and could even overestimate risk. But what's interesting is look at the numbers of the patients taking CIBINQO, 0.30 in 100 and 0.28 in 200. Again, this is the incident rate per 100 patient years. Then look in the Kaiser cohort per 100 patient years, 0.26. You can see the numbers are extremely similar. And look at, again, venous thromboembolic phenomenon. The Kaiser cohort number is 0.20. The non-fatal VTE in CIBINQO is 0.05. So again, this is you can't make a direct comparison between this clinical trials and this cohort, but what I'm trying to emulate here is a real world scenario of this entire group of cohorts of patients and helping you to kind of understand the context.
I mean, the reality is people get MACE events, venous thromboembolism, malignancy, regardless of whether or not they're on abrocitinib or Janus kinase inhibitor or any other treatment for that matter. These things happen in people in the general population, even without atopic dermatitis. So
absolutely, and
we're not seeing it go off the charts because they happen to be on abrocitinib, right?
That's the message here, and
right.
and that's how I like to interpret the data, because the numbers speak for themselves. Again, for the audience and in the interest of always remaining compliant and on label, I want you to understand that no comparisons can be made between the CIBINQO clinical trial rates and observed rates in the cohorts of patients with AD, but I hope this provides additional context. Next slide. Looking now at adverse reactions. So let's talk about the most common. What were the most common adverse reactions? Nasopharyngitis, nausea, headache. Those were the top 3. There are very low rates of discontinuation in the study due to adverse events. The patients who experienced the adverse events, for the vast majority, continued the study. Notice some of the other ones that are listed. I wanted to point out herpes zoster because we talked about that. Notice that in this placebo-controlled trial for up to 16 weeks, there were 2 cases of herpes zoster in the 100, 7 in the 200, 0 in placebo. The percentages, therefore, are not high. So when you talk to a patient about, hey, I'm going to prescribe this for you, and the most common side effects you're probably going to potentially even see, if that, are nasopharyngitis, runny nose, sore throat, cough, cold, nausea, and headache. Those are the 3 most common. Could other things be possible? Yes, but this allows you to counsel your patient compliantly and on label based on what was seen in the data. Next slide. So now let's talk about the actual clearance initially. Remember I said we're flipping the script. We started with safety. Now we're going into clearance and itch. And then I'll also, by the way, there's some great clinical pictures I want to show you, some new pictures that have not been included before in this deck that are really powerful. Let's go to the next slide. So this is where I start talking about studies. And I don't want anyone to glaze over for this part. This is important, but I'm going to try to make it simple. I want to talk about 3 key studies and 1 ongoing study. So 4 studies. JADE Mono 1 and 2. When you hear of that, these are the pivotal trials. 2 identical, double-blinded, placebo-controlled monotherapy studies, patients ages 12 and above, and they were either in 100 milligrams, 200 milligrams, or placebo. They were primary endpoint was EASI-75 and an IGA response at week 12. Then there's the JADE Compare study. Love talking about JADE Compare. It's compare because it's comparing CIBINQO 100, 200, dupilumab, and oral and/or injectable placebo with topical corticosteroid. What does that sound a lot like? It sounds a lot like being in clinic and managing these complex visits. And then there's JADE Teen, a 12-week combination study with topical corticosteroid, 100, 200, placebo once daily, ages 12 up to 18. So a dedicated teen study. And then finally, the 4th one is JADE Extend, the extension, the long term, and that's ongoing. The interim analysis is what allowed me to present some of those other numbers to you earlier. For example, the patients who have been exposed for almost 4.5 years. And then there's a JADE Extend post hoc analysis, which will be forthcoming. I'm really excited for whenever that will get published, and I'm really excited to see some of that data myself. Next slide. So let's talk through these studies. The way the next few slides are going to work, you notice that there's 3 sort of arc-like tabs at the top. So first, I'm going to talk to you about the JADE Mono study, which was monotherapy, specifically Mono 2. Then give you data on CIBINQO plus the topical steroid and JADE Compare, and then give you some long-term. So in CIBINQO monotherapy, EASI-90, that was a secondary endpoint. But remember, EASI-75 was a co-primary endpoint along with IGA of 0 to 1. What you see here is that both CIBINQO 100 and 200 were statistically superior to placebo for both co-primary endpoints. CIBINQO 200 performing even better. And for EASI-90, look at the data between CIBINQO 100 and 200 at 24% and 38% respectively. Next slide. Some clinical pictures. Remember I said I'm showing you pictures. 28-year-old female, abdominal AD. Look at by week 2, and then at week 12, she was a 1, almost clear. This is just an example of specific areas of skin clearance. Of course, patients who were enrolled in this study had AD in multiple parts of their body, but I wanted to show you this specific example to even show you the 2-week clearance. You can imagine that that's a very happy patient. Certainly in my practice, that would be. This patient was in Mono 2 at 100 milligrams. Next slide. Itch reduction in the monotherapy study. What I love talking about itch is the PP-NRS values were measured daily through the first 2 weeks. We wanted to know how the patients were doing on itch every single day, and then also at weeks 4, 8, and 12. When you look at these data, they're viewed as reflected as weekly average of the daily values. And what you see here is that you had a greater than 5 times versus placebo PP-NRS reduction or itch better in placebo versus CIBINQO 100. I just wanted to call that out. And then when you look at the post-hoc endpoints, look at the PP-NRS of 0-1. This, I will just mention, this post-hoc endpoint was not controlled for multiplicity. So you don't want to interpret this as evidence of superiority or non-inferiority or similarity of a treatment arm. But what it helps you to see is this PP-NRS of 0-1 as a post-hoc endpoint. And the recommended dose of CIBINQO is 100 milligrams once a day, ages 12 and above. But if the response is not adequate, you could consider increasing to 200 milligrams, and then of course discontinue if inadequate response is seen after the dose increase. Okay, so recommended dose is 100. Next slide. And then this just helps you to understand what I mentioned earlier, that PP-NRS. So just look at the slope. Remember I said royal blue is 200, higher dose, itch goes down even faster. The greenish, nice teal color is the 100, and then gray is placebo. So notice that the differences in the PP&RS average change from baseline between both doses of CIBINQO and placebo were observed all the way through week 12, but starting within 24 hours of the first dose. And I actually tell my patients that based on the studies, you may have itch reduction within one dose. And you can say that because it's in the data, it's in the studies. You're not promising, you're sharing a data point. Is that gonna be something you guarantee? Well, of course, we don't guarantee anything in 24 hours, but I give optimism and I give hope, and I want my patient to also follow up and give us feedback or call my nurse and let me know so we can make a note in the chart. And then when they come for their follow-up check, we can talk a little bit more in detail about it. Next slide. So now let's look at the data of CIBINQO 100, again, teal green, royal blue 200. Now you've got placebo still in gray, but you've got this purple addition. Very interesting. Now we're adding another color. Why are we adding another color? Because that was dupilumab, the 300 milligrams every 2 weeks. What you can see here, I think, speaks for itself. Look at the first 2 weeks and then the co-primary endpoint at 12 weeks. Look at the performance of 200 and 100, but also look at the performance early on in the first 2 weeks. Look at that upslope of 200 and 100 compared to the dupilumab slope and the placebo slope. Again, we're not interpreting these results for superiority claims. That's not what I'm trying to tell you. What I'm trying to tell you is just look at the numbers and you look at the way the graphs are flowing and where patients end up within 2 weeks, 4 weeks, 8 weeks, and 12 weeks in this study. Next slide.
You know, you're looking at the overall
Yeah.
general cadence of the response over that period of time, right?
Correct. Exactly.
That's what.
You're really seeing their pace. Exactly.
Right.
Yep. Great way to look at it. Oh, and then let's go back real quick because I do want the audience to see this. And let's click perfect right there. Because notice that when you get to that key secondary endpoint as well, what are you seeing? You're even seeing steady, and you're seeing those numbers continue to stay strong. So what it helps me to tell my patients is my prediction based on the data is that you're going to continue to do well. Next slide. Again, clear or almost clear skin versus placebo at week 12. Very important. Remember those co-primary endpoints. This is also something that you want to remember that for IGA 0 and 1, dupilumab was included as an active control. You see the statistical significance here. You see the week 2, the week 4, the week 8 data. And I think this really helps us to know when you're looking at IGA. Remember, IGA is skin clearance, whereas the EASI score, you're looking for actual involvement. IGA is what you walk in the room and say, wow, you're clear today. You're clear with just a faint bit of redness left on your forearm.
And you have to remember where they started. These people were at least half covered with eczematous dermatitis. They had the itcher, obviously, it's not assessing in the clear or almost clear. Their itching was dramatically improved. But picture what they look like. And now you have no evidence of active disease or very little active disease. It's a major change.
And you know, Jim, to your point, this is why I love I love taking pictures. You know, and I think, Jim, haven't you seen those patients who come in and you walk in the room and in like 10 seconds, you're like, oh my gosh, you look incredible. And then the patient says, really, I do? And you're sort of shocked that they themselves don't think they look as clear as you do as the doc. And that's why the pictures come in really handy. Because sometimes I go in and I'm like, okay, how are you not seeing how much better you are? And it could be that these people, you know, you look at yourself every day, you live with it for so long, you don't know what's better at that point. And so showing clinical images, I think, is one really important way to do it. You know, everyone's got a smartphone these days with a camera. I don't think I've seen anyone who doesn't have a phone with a camera. I tell patients, if you don't want to see my pictures, take your own and create a little folder on your iPhotos or in your photo album. Take one picture a week, and then when you come in, let's flip through all of them and you'll see.
Well, there are different types of patients, right? Some people get the general feeling I'm doing a lot better, even if they have a few patches here and there. And there are other people that focus on the one that's left,
That's
right?
right.
Right. And they don't put it into, so it really is helpful to bring that back to the reality of it, right?
Right,
This
exactly.
is what we deal with, right, Samal?
This is what we deal with. And then I sort of like, oh, this is going to be one of those visits. Because I'm thinking, you're clear, you should be happy. This is going to be a quick follow-up. You're going to be happy and give me a good review on Yelp, and I'm going to see you in 6 months or 3 months. And those end up being some of those visits where it's almost like I have to convince you that you're better. And
Doesn't
those
happen very often, fortunately, with these patients, but it does happen.
Right. Probably happens more in our acne world, right, Jim, than it does in our atopic dermatitis. Our CIBINQO patients are really happy. Okay, let's click through the next slide. And then this build again shows you again, that improvement. Same with Easy 90. I know this is starting to seem repetitive, but that's the point. I showed you primary endpoint. I showed you IGA. Now I'm showing you Easy 90. Same thing, the persistent improvement, giving you that picture of where the patient will land. And guys, Easy 90 is a tough endpoint. Okay, I just want people to know, in my opinion, Easy 90 is a tough endpoint. And people will argue with me, Jim, maybe we should ask Mark Leball what he thinks. I would argue that Easy 90 is harder to achieve than PASI 90 or PASI 100. The disease states are so mechanistically different.
Right. Well, it's easier for atopic dermatitis to fluctuate more quickly than psoriasis in terms
Absolutely.
of, being triggered and changing where the patients are at. Right. But we're picking on Mark Lebow's disease. We better stop.
I know, we're going to get an email after this from Mark. And Mark, if you're watching, we share that with you out of love, and you know.
We love you, Mark.
So, and let's click through one more time. You'll see the build all the way down to Easy 90. We can click one more time, and you'll see that nice advancement similar there. Okay, next slide. So we're doing good here. So here's more pictures. Look at this guy's face. Not just the erythema. Notice you can see scale and like conification in this. You don't even need to zoom in. Look at his forehead and his periocular area. This patient was on 200 milligrams plus a topical steroid, a 21-year-old. Look at him at week 2, and then look at him at week 12. This is a really beautiful example of skin clearance. Next
now,
slide.
that doesn't necessarily mean that he applied topical steroids to all those areas. It's just in the study that you could have used them, correct?
That you were allowed to use it. That's absolutely right. Yep. And then speaking of patients who were in the study, looking at itch again. Remember, I showed you the itch and PPNRS in the monotherapy just a minute ago, which was that first ARC-like tab. Now in this CIBINQO plus TCS, look at the PPNRS here as well, between the 100, the 200, and the dupilumab arm, as well as the PPNRS of 0 to 1. So this is the key secondary endpoint on the left, the post-hoc endpoint on the right. Notice placebo was, when you look at that number, 8%.
And this is at 2 weeks. This is within the first 2 weeks.
Correct.
Yeah.
This is at 2 weeks. And remember, we also showed you the data, which is in the studies, that the potential for even improvement in 24 hours. Because remember, guys, in the first 2 weeks, we were getting itch scores every day. Patients were asked, they had to track it every day in the first 2 weeks. That's how you can get these numbers.
Yep.
Next slide. And then if you look here at this post hoc analysis, now this looks at skin clearance at week 12 as predicted by itch response at week 2. So what we're trying to look at is for those itchy people who responded at week 2 with itch, what is their skin going to be predicted to look like at week 12 because their itch got better? That's one way to think about it. Where would they be? So if you look here at Easy 90 response, based on the PPNRS score at week 2, what do you see? You see the responder columns at 54.4%, 59.2%, and 36.7%. So that's the percentage of patients. And I hope everyone likes what this is showing because, again, this is giving you an example this almost gives me my quote unquote crystal ball, right, Jim? This kind of gives you a way to think about predicting. And this is something that I find really, really helpful. Next slide. Again, these were post hoc analyses. Okay, and then finally, the long-term extension, which is something right now that we have the interim analysis. These were all the subjects who were rolled, including those who rolled over from the 1 phase 2 trial, 4 phase 3 trials that we talked about, and the 1 phase 3B. So that cohort, the ones who were on 100 got rolled into extend into 100. The ones who were on 200 got rolled into extend on 200. So if you're on a dose, we stayed on a dose. But if you're on a placebo during the randomized phase, then you were randomized to either 100 or 200. So what's the point? Everyone's on something. Okay, everyone's on 100 or 200 because we want to get long-term data. The interim analysis was done at week 112. Remember, I told you there's still a longer post hoc analysis that's ongoing. Next slide. And if you look here at these interim analysis and the skin clearance response, I think the message, without me belaboring every number, is that you get the patients rapidly achieving that 75% improvement. Those were the early weeks. And then you see this sustained, and the word sustained to me is probably the most important word because this is looking at EASI 75. So sustained EASI 75 all the way out to week 112. And you can see that for 100 and 200. And then looking specifically here at the observed data and the MNRI, look at the numbers. And I'll show you on the next slide as well. So we can break this down also if you wanted to look at EASI 90. I can tell you that the curve is similar. If you want to look at IGA, consistent. Okay, so these endpoints are consistent. Now, these interim pooled analyses are descriptive. And there was no comparator group, so I do want to be fair and mention that. So they're, they really want to review these results with caution, but the numbers are the numbers. And you look here at this interim analysis, we'll wait for the post hoc analysis, which I'm very optimistic about. Next slide. Okay, here we're looking at the same thing, the itch reduction response. Remember, this was the PP-NRS4. You're probably at this point getting the pattern. You saw EASI, you saw IGA, you saw PP-NRS4 in CIBINQO mono, JADE mono 1 and 2 data I showed you. You saw the same in COMPARE with CIBINQO and TCS. Now you're seeing this in long-term extension because remember, we're looking at what they did long-term. Look at their itch scores and the sustained PP-NRS. This is based on daily values. Again, pooled analyses, we all know they're descriptive. There's no comparator group, so we'll just review these results in the sphere of what they represent.
Well, there's consistency of the outcomes, regardless of what lens you're looking through. You mentioned different ways and at different points in time. Now you're looking down the line. The outcomes are consistent.
Yep, they're very consistent. And that's what you want to see. I mean, that frankly, as a doctor, that's what I need to know because I need to know that this is going to remain consistent. And I tell my patients, I have data now to say, this is what I expect. Does it always go like that with everything we do in dermatology? Of course not. That's not what happens in medicine in general. But at least you have footing to stand on when patients ask these questions. Next slide. And then finally, we're looking again here at, the JADE Compare, the JADE Extend, the long-term safety data. Now, also, we wanted to see the patients, remember the patients in the JADE Compare could have been on dupilumab plus the topical corticosteroid and the emollients. Then they would have a washout. And now we're looking to see the dupilumab responders and those non-responders, what happens to them when you then randomize them into extend onto either 100 or 200. And there were a subset of patients who were defined as dupilumab non-responders, the ones who received dupilumab plus the steroid but didn't achieve the endpoints. Those patients then had the washout and then got put into JADE Extend. Next slide. And if you look again at these post hoc analyses, here on one slide, you're looking at EASI 75, EASI 90, IgA, PPNRS4, PPNRS0 and 1. So all the endpoints that we've talked about, you're looking at these among the prior dupilumab non-responders. Again, I'm not making conclusions regarding treatment differences. I'm just presenting results. And here you see the percentage of patients who achieve efficacy responses with or without topical steroid from these dupilumab non-responders.
So Samal, as an example, if I'm interpreting this right, if you're looking at EZ75 week 12 after they're now on either CIBINQO 100 milligram a day or 200 milligram a day, in the patients that did not get to EZ75 with dupilumab, if they were on the 100 milligrams a day, 68% of them that was switched to CIBINQO did achieve that EZ75 by 12 weeks. All right, so you can do that for each of these endpoints. Correct. And see what those results are, right?
That's exactly right. And again, you see that the 100 and 200 are both shown on the slide to Jim's point. Yep.
Right.
Next slide. So let's close now and then open it up to questions by finishing on initiating treatment. So let's go through the last few slides. And we can go ahead and go to the next one. So just a reminder, 100 milligrams once daily recommended dose with or without topical steroids, ages 12 and above. If a patient's not responding to 100, you can consider increasing. Patient should not crush or chew the tablet, just swallow it whole. By the way, it's with or without food. I think that's important. Patients need to know how to take it, and they ask those questions. If the patients do get nausea, which was potentially an AE of those top ones that we listed, maybe take it with some food. And by the way, there is a 50 milligram dose available for patients with moderate renal impairment or those who are on some of the strong inhibitors or poor metabolizers through the CYP pathway. So there is a 50 milligram dose. That dose was not studied in clinical trials, but it is available. Next slide. Again, this renal impairment concept, think about for the patients with a moderate renal impairment, so a GFR of 30 to 59, you can do 50 once a day. If you have someone with severe hepatic impairment or severe renal impairment, you don't want to use it. And then again, this concept of these CYP drugs, so for example, fluconazole, rifampin, fluvoxamine, just make sure you look at concomitant medications. All of these things we all do anyway when you're looking at a patient's med list. But it's important to call this out, and I appreciate having this information on a slide just to put on your radar. Next slide. And with treatment, when you look for labs, when we look for evaluation at baseline, of course, we talked about screening for active infections. You check a blood count, make sure patients are up to date on immunization, and then you screen and you counsel accordingly for those MACE, thrombotic, and malignancy events that we talked about. 4 weeks later, 1 month in, check another CBC and a lipid. And then ongoing therapy is just monitor these patients for infections, MACE events, thromboses, and malignancies. But the lab monitoring for throughout treatment is really based on patient profile, symptomatic. Are they developing hematologic problems? Are they someone who, when you screen them, had borderline lipids or had a lymphocyte count or a platelet count that you wanted to recheck but that you weren't worried about? Obviously, active viral hepatitis, you would not want to use the medication.
So what I like is what's on the right. When you're getting your baseline labs and your assessments, it's telling you exactly when you have to be concerned to not start. It
Yes.
tells you what platelet count to look for.
Yes,
and then during treatment, when you might have to temporarily discontinue, it's outlined for you. Really,
it is outlined for you, and this is really helpful information. Next slide. So in summary, I hope we've been able to cover the fact that CIBINQO really represents an incredibly rich addition to our therapeutic armamentarium for moderate to severe atopic dermatitis, with once daily dosing that really helps provide meaningful itch reduction, proven by the data in the studies, really powerful skin clearance versus placebo, and also showing you data in combination with topical steroids and dupilumab. Long-term data has been presented and is even more on the horizon. And we have patients now with close to 5 years of exposure to the drug and close to 4,000 patients who have had a well-demonstrated safety profile.
So Samal, we have a couple of questions here.
Great.
I can just address a few of these that came in. I've been monitoring for that.
Thank you.
We're monitoring, right?
We're monitoring.
Right. So with all the choices that we have available, there may be other therapies other than a Janus kinase inhibitor like CIBINQO, abrocitinib, that you could think about using. How do you decide when you're going to use, what patient you're going to utilize? In this case, let's say CIBINQO, that has moderate to severe atopic dermatitis. They've already been on, some other therapies, systemic prednisone. They may have been on a biologic, one of the biologics, maybe even one of the older therapies, but there are other choices. So how do you decide when you're going to use JAK inhibitor therapy with CIBINQO?
Well, I think for me, one of the things that I really like to do for my patients for CIBINQO is to really think about that itch component, that dosing flexibility component, obviously the age component of that patient, and if they failed a biologic with a topical steroid or a biologic alone, or they're having a contraindication, I really know that the CIBINQO data allows me to feel confident in itch relief quickly and in maintaining that dosing flexibility of that once daily dose with the option to titrate up. And I like that flexibility to be able to start and say, I'm not at my ceiling. I've still got runway to go.
Right, you have a runway ahead of you. Now, how do you counsel female patients of childbearing age?
So first and foremost, you do not prescribe these we don't have data in pregnancy and lactation. You would not want to put a pregnant female on an oral Janus kinase inhibitor. If my patient is planning pregnancy, it's shared decision making. I have had patients who were thinking about pregnancy, but who were so miserable from their AD, we had shared decision making about the timing of when they were planning their pregnancy. In some situations, we do urine pregnancy. We do those for isotretinoin in our office. That's easy to do for patients who may want to confirm they're not pregnant prior to initiating. And then it's a conversation also oftentimes between patient and their obstetrician gynecologist on the fact that I need to get their skin clear for this patient to feel comfortable in their own skin because they want to pursue a pregnancy, but not until their atopic dermatitis is better.
Makes sense, right? And they could also, they can also test their urine pregnancy tests at home. They're very sensitive. And then if it changes, they let you know and they discontinue. So we have some references there and we hit our final buzzer, Samal. So
thank you so much.
Any final words?
I really want to just say, Jim, thanks for helping to have a great discussion tonight. It's been really a fantastic opportunity to share new data. I hope for the audience this was helpful. I want to thank Leon and IDEF and also especially our colleagues and friends at Pfizer for their continued commitment to research and innovation in our specialty.
Thank you. And thank you for all you did during your presidency also, Samal. Thank you very much.
Much appreciated.
Thank you, Dr. Del Rosso. Thank you, Dr. Desai. It's been a wonderful presentation and such an innovation for atopic dermatitis patients. We'd also like to thank our audience for joining us this evening. And please remember to join us also on Thursday, May 8th from 7 to 8 p.m. Eastern Standard Time, where we are going to be talking about unlocking chronic spontaneous urticaria. Good night, everybody. Thank you.
Thank you.
Good night. Thank you.